tells. So this is something which is relevant to it towards the fact, of the you can say examination or the crime happened. So I welcome all of you on behalf of Department of Rachana Sharir, Ayurved Prasarak Mandal's Ayurved College SION. So let us begin with the examination, or you can say the steps and of the examination of skeletal remains in medical legal cases. I would like to give you certain examples. So objective of my session, at the end of this session, the participant should be able to discuss steps involved in skeletal examination, and the most important aspect of this session is medical legal importance of skeletal examination. So these are the two broad objectives of my session. So there are certain steps involved in the examination. So sometimes when we receive the skeletal remains, so that may not be bones. So the first step, whether the skeletal remains are bone or some other material. So this is mainly because nowadays the bone set is very expensive thing, and there are hardly any personnels who are having the license to sell the actual human or the original human bone sets. So most of the students, they are utilizing the bone set in the form of plastic bone set or in the form of you can say POP bone set. These bones are actually like original bones. So the gross anatomical features are exactly similar with the original bones. However, the internal structure, which is not exactly similar with the original one. So first thing, we'll have to concentrate on the gross anatomical structures. Means there are certain attachments, certain contours, certain depressions, certain ridges, certain tubercles, trochanters. So these are actually the things where you will get the attachment of muscles. So the gross anatomical structures, they are much more, plays much more significant role in identification of the original bones. Then when you go to microscopic examination, so there is typical or peculiar lamellar pattern you can observe. The Haversian system is there. So histologically or microanatomically, you can distinguish between bone. Further, you can distinguish between animal bone or human bone also. So this is you can say, or you can identify whether the given skeletal remains is bone or something else. Now, the second most important thing is the source of the skeletal remains. It may be in the form of human or maybe in the form of other species. So again, because I have received certain specimens, certain skeletal remains with animal bones also, which are mixed with the human remains. So again, this is identified mainly on gross anatomical characteristics, because human being is having erect posture. So the skeleton is modified or adapted in the different sense. Just like, if you see the femur or if you see the pelvis, which is differentiated, or if you see the skull bones, they are differentiated as compared to other human other animal species. So this is the gross anatomical characteristics. If you see the human femur, which is showing convexity, because the axis of gravity passing posterior to the hip joint and immediately anterior to the knee joint. So that's why the pull of the hamstring that forms one curvature over there. So that's why if you see all the human femora, they are convex forwards. So this is how the gross anatomical characteristics plays a significant role. And again, I just discuss about the microscopic examination. So what does this microscopic examination means? A microscopic examination is for a peculiar lamellar pattern. Peculiar lamellar pattern indicates the arrangement of bony lamella and the shape of the bone. So this is specific. The third important thing, that is precipitin test. So if you get a skeleton up to 10 years, you can go for this test that is called as antigen antibody test. So this antigen antibody test is very important. So this indicates, or what you can call it as a differentiate between human and other species. So this is for the second point was source, whether it was from human or from animal. And the third point is name of the bones. So whenever you are encountering certain skeletal remains, you will have to name, you will have to label the bones. Whatever you are getting for the examination, you need to label, because most of the things are in Greek and Latin words. So all these bones, they are having specific names, just like, femur is thigh bone, humerus indicates a funny bone, fibula indicates feeble, like needle-like bone. Then you can say tibia, a rod-shaped bone. Your clavicle is just like, Roman clay or the collarbone. Ulna is just like appears like a hook, and even you can say the scapula called as shoulder blade. So these are Greek and Latin terminologies for the bones. So you need to identify all these bones on the basis of gross anatomical characteristics, because again, the bones, they are classified on the basis of, long bone, short bone, pneumatic bone, miniature long bone, and you can say the modified long bones, irregular bone, flat bones. So on that basis, these are the gross anatomical features. On that basis, you can name the bones or the skeletal remains. Then whenever the skeletal remains comes to you for the examination, at that time, the most important thing, so whether it belongs to one individual or more than one individual. All may be of human species, that is fine, but that may be from multiple, you can say, sources of the human species. Just like, I would like to elaborate the famous case of 2006 case, that is Nithari. Everyone is aware with the Nithari Hatyakand case. So that in the Nithari Hatyakand case, multiple children were killed and thrown into you can say the Nala, which is crossing from the near the home of that, you can say, the accused. So here you can get multiple bones. And one more very important case in this scenario, that is, the famous actress Laila Khan and his family was killed near Igatpuri, Nasik. So when the skeleton were found, so there were identical twins. So in identical twins, the elements, you can say, the elements, that is the genetic elements in DNA fingerprinting, is possible for DNA fingerprinting in case of especially the long bones or the molars or the tooth pulp, which is utilized for DNA fingerprinting. Because recently I have encountered with one case where we have identified the skeletal remains by this DNA fingerprinting method. So in such cases, the DNA fingerprinting is also utilized. That is the extreme way. But before that, number, size, and side of the bones, because there are certain bones which are unilateral, certain bones which are bilateral. You can say the two bones are there, so right and left. So on that basis, you can identify the side of right and left bones. Then on the basis of age and gender. So age means the ossification center. We can identify the bones on the basis of you can say the epiphyseal fusion. Uh, and gender, male and female bones can be easily identified. We'll come to this section in detail. Then certain morphological similarity between the right and left side bones. So these morphological similarities are also useful to identify whether it belongs to one individual or more than one individual. Then there is one more way to identify use of shortwave ultraviolet light. So this can be utilized up to 35 to 100 years, where the decaying has already been started, if it preserved, even if it preserved in good condition. So the short wave or the ultra wave light actually passing through the bones, if they are of the similar species, it passes uniformly. But the bones, if the bone belongs to different species, then it doesn't pass in the uniform manner. Again, this requires the expert eye to visualize the things. Then you can go for X-ray comparison of trabeculum calcium content of the bone. That will also individual, you can say, that gives the appearance whether it is of the same individual or more than one individual. Then ultimately, very first we have seen the DNA fingerprinting. So you can utilize these two bones to identify whether they are of the same species or of the different species. Besides the you can identify this thing, but you'll have to go for one more crude test. That is, every joint, every individual's joints are identical, or you can say individual. Rather than identical, they are individual, because if you see the fitting, the snugly fitting of the respective joints indicates these are the bones of the similar species, rather than similar individual. Sometimes in Laila Khan case, what happened? There was identical twins. So basically, the DNA matches. The DNA of the two skeleton matches with each other. However, the snugly fitting structure, they are, even though in identical twins, the fitting is not snugly fitting. So this is one more characteristics one should keep in mind while uh, classifying these bones in the form of whether they are of one individual or more than one individual. Then now coming to the next point, that is what you can call it as a age of the individual. So most of the time, we are going to see the dental status of, if skull or mandible is available, the dental status gives very significant findings for you can say determination of the age. Then there are certain angles. There are two angles, what you can call it as a medico-legal and anatomical angles. There is slight difference between these medico-legal and anatomical angles of the mandible. According to some of the authorities, if you continue with the ramus of the mandible, anterior border of the ramus of the mandible, and the superior margin of the alveolar notch of the mandible, so that indicates one angle, that is called as medico-legal angle. And in anatomical angle, we are usually counting the angle, the lower border, posterior border, and the lower margin of the body of the mandible. So that is what you can call it as a anatomical angle. So on the basis of whether it is obtuse, acute, on that basis, this angle changes. So whether this is of the child or whether this is of the old person or whether this is of average age person, so you can easily determine or you can guess about the age. So that is one very important thing. The angle can be counted with the help of goniometer. Then the ossification data. The ossification data is already available. So the epiphyseal ends fuses. The just like if you see the upper end of the humerus, which fuses at about 20th year of life. So this is how you can identify the ossification center. In case of female, it fuses little earlier, around 1 to 2 years earlier as compared to the male. Then radiological ossification. If you see the fusion of radiological ossification is little later, because in radiological ossification you can see the inner structures. Here the ossification, if you see with the naked eye, so only the morphological ossification you can going to observe. So inner structure or the inner ossification things can be observed with the help of radiological radiograms, and to see the radiological ossification, which is little delayed as compared to what you can see with the naked eye examination or the morphological examination. Then there are certain changes. That is again the ossification thing. This is you can call it as a closure of the skull sutures. So closure of the skull sutures, which starts from the inner side, external side, and then the inner sutures would be closed. So this is how you can take radiographs, or in case of skull, to determine you can say the denture eruption of the teeth. So you can take OPG, that is orthopentagram. Then bony joint surfaces, you can observe the bony joint surfaces. If you see the pubic symphysis, the changes at different ages, you can determine which are already recorded. So you need to observe these changes. And then further, you'll get the medullary index also. Some of the authorities, they are of the opinion that medullary index, any index, whenever you are talking about any index, the index indicates the ratio of breadth to length multiplied by 100. So here the total diameter of the medullary cavity of the long bone and the total diameter, that is the outer aspect, the ratio multiplied by 100. So it goes on decreasing as the age advances, because the you can say the calcium content, because of certain osteoporotic changes, the calcium content of the bone goes on the size, the outer table, you can say the compactness of the bone goes on decaying, or you can say becomes less or the smaller. So this index becomes little less, the ratio becomes little less. The another point, which is very significant point, that is gender of the individual. How you are going to calculate the gender of the individual? So again, if you see the general characteristics, if you see the male bones, usually the male bones, they are in generalized way, they are heavier. Then the muscular markings, because genetically they are having the androgen or testosterone. So because of this testosterone, even though one is not going for workouts, still at certain time period or at the young age, when the androgen or the testosterone is at the peak, so at that time muscles are because for musculature it is the prerequisite, testosterone or androgen is the prerequisite. So that's why naturally male bones, they are heavier, and you can say showing the curvatures in the sense of the attachment of the muscles, where you will get the traction. So traction is one of the type of epiphyses. The tractions points, they are well demarcated as compared to the female. So now but the another question in the question arises in your mind must be, if you are saying there are certain females which they are also showing, they are bodybuilders, so they are taking androgens orally or some in injectable form, so their muscles are too strong as like male bodybuilders. So these are certain exceptions. However, there are certain other characteristics. So in this scenario, we'll go to specific characteristics, just like pelvis, which is differentiated in case of female, and in case of male, the skull bones, they are differentiated. So this is how you can calculate or you can diagnose the gender of the individual. So if you see the average weight, if you are getting a complete skeletal remains, so average weight in case of male is around 4.5 kg. These are average values. These are not exact values, but average values. In case of females, the weight is around 2.75 kg. So this is somehow some of the authorities, they have found out these figures. So I am just quoting these figures. If you see the vertebral column length in case of male is around 70 centimeter. In case of female, it is around 60 centimeter. This is a generalized approximation. Then the clavicle length in case of male, it is around 151 to 153 mm. And in case of female, 1.38 centimeter. Okay, like that. The diameter of the head, in case of male, it is more or equal to 72 mm. And in case of female, it is less than 71 mm. So these are certain the diameter of the glenoid cavity also. So these are certain, you can say, the regression equations studied by certain anthropologists or anatomists, and they have found out these are the ranges where you can diagnose whether they are of the male or female origin. So why these specific characteristics are required? Because when you are getting certain bones with or in pieces, no complete skeleton is available at that time, this may help you to determine the gender of an individual. So there are certain specific changes in individual bones. In case of skull, you can see the male skull and female skull. So left one is the male skull and right one is the female skull. So here you can see the supraorbital margins, then outer, you can say the angle of the mandible, then uh, zygomatic bone. So these are certain changes. Then certain eminences. Here you can see certain eminences which are present. So these are called as frontal eminences, which are more prominent in case of females. Likewise, in case of male and female pelvises, the subpubic angle is crucial. Then the shape of the inlet is crucial. Then the sacral index is very crucial. And the preauricular sulcus, which is very significant in case of paras female, which helps to determine basically the gender of the individual. So if you are getting only pelvis, so this formula is called as Krogman's formula. So Krogman has decided and quoted certain figures. So that is called as Krogman's formula or Krogman's rule. So if you are getting only pelvis, so you can identify the gender 95 correctly. You can identify the gender. If you are getting only skull bones, so you can comment 92% accurately on the gender. Then if you are getting long bones, so 80 to 85% correct assumptions would be there. Then long bones plus skull, so that goes to 96, that is more accurate. And if you are getting long bones plus pelvis, so 98% accuracy is there, and pelvis plus skull again 98%. And if you are getting complete skeleton, so of course you are going for 100% accuracy to diagnose the gender of an individual. Then there are certain indices which were calculated by certain anthropologists and certain anatomists, and the regression formulae, they have statistically produce a certain formulae, and they are saying that around sacral index. So here you can see now again the indices. Whenever you are talking about indices, so any index is a ratio of breadth to length multiplied by 100. So whenever you are talking about sacral index, it is the maximum transverse diameter, including the sacral promontory, that is for sacral vertebra, and the alley. So that is the base, and from sacral promontory superior to the fifth sacral vertebra, that forms the length. So that is the ratio multiplied by 100. So in case of male, it is 112. In case of female, it is 116. So in case of male, the sacrum is slender, and you can say conical in shape. In case of female, it is broader. So the another index is ischiopubic index. So what is this ischiopubic index? The length of ischium, total length of ischium to the total length of pubics. That again forms one index. In case of male, it is around 73 to 94. So these are always ranges. So this would help when you are dealing with individual bone, not as a whole. Then in case of female, it is around 91 to 115. So this is the ratio. Then there is one more index, that is corporobasal index. So this corporobasal index is calculated. This is mainly to identify the male sacrum, basically. So on the basis of this curvature, because in case of male, it is more curved. In case of female, it is backwardly placed and it is less curved. So the transverse diameter of first cervical vertebra, ratio of transverse diameter of first cervical vertebra to the transverse diameter of the base of the sacrum multiplied by 100 indicates the corporobasal index. And this this was calculated in case of male around 45, and in case of female around 40. So this is mainly to identify whether the sacrum belongs to male or not. Then the sternal index, again the breadth to length ratio. In case of male, it is 46, and in case of female around 54. So again, the sternal index is a significant finding to identify or to comment on the gender. Then there was one formula, that is Buchanan's formula. This Buchanan formula indicates if you are getting complete skeleton and you are weighing this skeleton. So in case of male, it is 5 kg, around 5 kg, and in case of female, it is 2.5 to 2.7 kg. So this is what Mr. Buchanan has identified, the average weight of male and female, you can say, the skeleton. Now let us move towards one of the sensitive topic, that is called as a race. So let me tell something about before moving to the race. The term race do not exist in human species today. However, the old racial categories were based on externally visible traits, primarily skin color, features of face, shape and size of the head, body and underlying skeleton. So this is how the racial difference is. So in American Association of Physical Anthropologists, there was one statement which were published in AAPA statement on biological aspect of the race, which published in American Journal of Physical Anthropology in 1996. So this anthropological congress you are not going to call the term race as such. It should be in the form of ethnic origin. So what is this ethnic origin? These are nothing but culturally or geographically isolated group of people or the population. So race leads to racism. Hence, the term race do not exist in today's world. So let us go back towards the little historical appearances of these races, because earlier anthropologists, they have studied the race as such, or the peculiarities or the external peculiarities of the human species on the basis of races. So primary races were Caucasian, also called as white races, Mongoloid, also called as yellow races, Negroid, or also called as black races. Then further classification, further two more additional classification by Blumenbach's classification. So that is a well accepted classification at the time. So Caucasian, Mongoloid, Ethiopian, American, and Malay. So these were, so he has added red and brown. These were on the basis of skin color, primarily skin color. So on the basis of racial peculiarities, certain anthropologists have already studied and put a data for, you can say, in the form of various indices. So let us see this data. So if you see the cephalic index, so this is the index which actually indicated the shape of the skull. So on this basis, so these are certain Latin terms. So dolichocephalic is basically long-headed individual, mostly appearance in Negroids and Indians. So the index, again, the ratio of height of the skull to the braid. So height would be calculated if you are including skull to the vertex, and from two parietal eminences, that would be the braid. Ratio of braid to the height, that is, here it can be called as length. So on that basis, cephalic index can be calculated. So it is again further divided: dolichocephalic, that is long-headed individuals, which mostly observed in Negroids and in Indians. Then mesatecephalic, that is medium-headed individuals, mostly observed in Europeans. Then brachycephalic, that is round-headed individuals, mostly observed in Mongoloids. So this is what you can call it as a cephalic index. On this basis, there are further more indices. One more is called as brachial index. So what is this brachial index? This can be calculated in skeleton as well as in living. So the ratio of total length of radius to humerus multiplied by 100, that is called as brachial index. So in case of European, around 74, in Indians around 76, in case of Negroid population it is around 78. So there is slight changes in brachial indices also. Then crural index. So what is this crural index? Again, a ratio of total length of tibia to the total length of fibula multiplied by 100. So here it was calculated, the regression, through regression, the indices were calculated in case of European 86, in case of Indian 86 again. So there is hardly any difference between this European and Indians. And in case of Negroids, again, you can say 86. So after counting here, you can of the opinion that crural index is not of the use to a good indicator for ethnicity or to classify the racial features. Then intermembranous membral index, that is total length of humerus plus radius to total length of femur plus tibia multiplied by 100. So here it is in Indians, it is significantly differentiated through Europeans and Negroids. However, the Europeans and Negroids, they are showing the similar value of this index. And then in case of humerofemoral index, it is basically total length of the femur to the total length of the humerus. And again, there is slight difference in case of European, Indian, and Negroid. There is one more index that is called as pilastric index. This So that is a line which is present on, which is a thickened line, which means the thickened line which is present on the, you can say, all the adductors, they are attached on the posterior aspect due to erect posture. All these adductors, they are coming on the posterior side of the femur. So that line is called as linea aspera. So anterior posterior, the ratio of length of anterior posterior to the lateral length. Multiplied by 100. So that is basically the pilastric index. So there is slight difference between Turanians, Aryans, Negroids. So these are, you can say, the ethnic origins, various ethnic origin representatives. So they are showing slight differences in this indices. Then there is one more index that is called as Cunningham's index. That is a development of lumbar curve. So what is this? How the index is calculated? Sum of posterior height of lumbar vertebrae to the sum of anterior height of the lumbar vertebrae multiplied by 100. That is called as Cunningham's index. So on this classification, so you can say the orthoarchic, that is Aryans, orthoarchic, that is Indo-Australians, and polyarchic, that is Khoisans. So these are various ethnic origins. So indices above 100 shows absence of strongly developed lumbar curve. So this again indicates, habitual things of that person or certain anomalies of that person. So this is how the Cunningham's index is carrying importance. Then on the basis of sacrum is a bone which is a sacred bone, or you can call it as a holy bone, because in living person you cannot feel this bone. However, during skeletalization, after skeletonization, you can see this bone. So that is called as holy bone. So the length to the breadth, which I have already explained you, the maximum sacral length from the breadth to the mid-ventral straight height, this ratio multiplied by 100. So on this basis, again, the sacrum is classified as per, Dolicho rake, that is narrow, which is observed in Turanians, Negroids, and Khoisans. Subplaty that is medium size, and platy that is wide sacrum. So this is again, you can see this, what you can call it as a categories given by the anthropologist. On the same basis, if you are looking at certain pelvis. So pelvis is a Latin word which means basin. So there are again, certain types of pelvis: android pelvis, anthropoid pelvis, gynecoid type of pelvis. So most of the negroid individuals, they are showing android type of anthropoid type of pelvis. So anthropoid type of pelvis, they are represented by negroid females, especially the negroid females. Usually the gynecoid type of pelvis is represented by females, and anthropoid type of pelvis is represented by males, and that can be identified by the shape of the inlet. So here heart shape is android, oval shape is gynecoid type of pelvis, and oval shape but anteroposterior oval indicates anthropoid type of pelvis, and another one is, you can call it as a platypoid pelvis. This platypoid pelvis type of pelvis is observed in duckbill platypus. And in case of other individuals, if there is a deficiency of vitamin D, so in the cases of rickets, you can observe such type of pelvises. So all neonates, and you can say all negroid females, they are showing platypoid type of pelvis. So there is one more index that is called a sacrum curvature index. So that is mid-ventral straight height and mid-ventral curve height. So straight height and curve height, there is slight difference, and this ratio multiplied by 100. So again, in anthropoids, the range is 98. In Indo-Australians, 93. Negroids, 92. Khoisans, 88. Turanians, 85. And Aryans, around, the range is given 84 to 86. Anthropoids is the term which is actually relevant with the other primates besides human beings. So what are those other primates? They are chimpanzee, orangutan, gorilla. Likewise, these are called as primates. So they comes under anthropoids. Then there is one more index that is called as height index of the skull. So again, total height. In case of Europeans, it is 75. Mongols, it is European 71. Mongol, it is 75, and Negroid, it is 72. So there is slight differences, and the shape is calculated. Then there is one more index that is called as nasal index. So this nasal index, and there is one more index which is called as nasal elevation index. This nasal elevation index can be calculated in case of living, which is basically calculating from the length which is calculated from the subnasal to the pronasal point, the prenasal point. So the prenasal point is not available in case of skeletal remains. So that's why only nasal index can be calculated from nasion to the subnasal point, that is anterior nasal spine, and the maximum transverse diameter of the nasal cavity. So this nasal index is again important because you can easily know, this is the most distinguishing feature of the face. So you can easily distinguish between Negroid individuals or European individuals. So on this basis, the noses can be categorized like hypercamorrhine, camorrhine, then medium sized noses, then leptorine, or narrow noses, or hyperleptorine noses, that is a very narrow noses. So on this basis, this nasal index is important, and again it shows significant degree of deviation in case of all racial or ethnic origins. Even it shows certain difference between male and female also in some degree. Okay, so now there is one more thing that is called as body height and length. Body height, or you can say the length. So use of multiplication factor in case of certain authorities like Shah and Siddiqui. These were the two authors who have found out certain constant which gives after regression they are going to give you the average height of that individual. So this is one more thing. And in case of foreign individuals, Carl and Pearson. So that is Carl Pearson formula, and another one is Shah Siddiqui formula. So if you are going to calculate the upper half and lower half, so upper half is up to the upper border of the pubic symphysis. That indicates the upper half and lower half of the body, and below the pubic symphysis up to the foot. So that would be the lower half body. So why do you know this upper half and lower half of the bodies? What is the need? Because sometimes you are going to observe the skeleton in the mutilated bodies, because the bodies get mutilated and you won't get a full skeleton as such. So at that time, one should be able to identify if the body is of the same human being, and if you are getting upper half or either lower half, so you can calculate total height of the body. Then length of the full extended both the upper limb from the middle finger indicates the total length of the body. Then length from suprasternal notch to the pubic symphysis multiplied by 3.3 indicates the complete height of the body. Then length of the upper limb multiplied by 2 plus 34 centimeter, that is thoracic region, indicates the complete height of the individual. And length between two olecranon process and tip of the middle finger is actually 5/19 of the total stature of an individual. And length of the vertex to the chin, only you are getting only skull and mandible, you can say. The skull and mandible, basically when you are calling it as a skull, so the mandible is attached to the cranium. Otherwise skull and cranium, they are synonymously called as skull and cranium. However, when you are attaching mandible, it would more precisely you are calling it as a skull. So from the mental, you can say the base of the mental tubercle base and vertex, that is the height. So if you are calculating this height and you are multiplying by 8, so that would indicate the average height of that individual. So we have calculated the average height of this of one of the individual by only examining the skull. Then the vertebral column is you can say 3400 of the total stature. Then the entire skeleton plus 2.5 to 4 centimeters soft tissues. Whenever you are including soft tissues, so some certain constant has to be there. So that indicates the height. If you are if you are getting only ulna, so if you are multiplying with 6, then you will get the average height. Radius multiplied by 6.3 gives the average height of that individual. Humerus multiplied by 5 gives average height of the individual. Tibia multiplied by 4.2, so it gives average height. Fibula multiplied by 4.4 gives average height, and femur multiplied by 3.6 gives average height of that individual. So in case of weight and humid bones, the long bones, you will have to minus 7 mm, or in case of tibia minus 5 mm, or in case of humerus minus 3 mm. So you'll have to minus these things in case of weight or humid bones. If you see the regression of the structure, so the regression of the structure is 1 mm per year. If it is in a good condition, so it is average is 1 mm per year or 2.5 centimeter per 25 years. So this is what you can call as a decaying of the bones as the time progresses. Then identification. This is again the most important factor, identification. So why do you need this identification? Because if you are getting certain skeletal remains with certain anomalies, so one should not mislead with certain congenital abnormalities or deformities, because certain individuals, they are having in not similar bones of right and left side. Because of the wasting of the muscles, that skeleton also becomes little smaller throughout the year, and the deformity indicates the congenital abnormalities. Then you can see the acquired peculiarities. There are certain acquired peculiarities, like injuries due to an accident, mechanical trauma, etc., fractures. So again, here pre and post-mortem fractures are important. So here the pre-mortem fracture is basically the fracture which happens when the you can say the individual was in living stage, and in certain accident or in certain homicide, if or murder, you can say the individual are beaten to death and by fracturing his or her bones. So there are certain nutrient vessels which are present around the bone, or some of them are inside the bone. So that gives seepage permanent, and that seepage is accumulated in the bone. So that gives peculiar stain to the bone, and that stain doesn't vanish even after washing. So this is most important pre mortem fracture. In case of post-mortem fracture, there could be stain, but that stain is not in the form of seepage inside the bone, and that could be easily washed out. And you can test this, you can say, stain with the help of antigen antibody test. Then a determination of blood group from bone marrow. So benzidine test up to 150 years, and this can be tested with the help of two people. So there are certain experts at forensic sciences laboratory, which gives the expert opinion with the help of certain chemical analysis of the bones for DNA fingerprinting or blood groups or antigen antibody testing. Then age, gender, race, or here you can call it as the ethnic origin, and stature of the individual is also important to see the congenital anomalies. And finally, the radiological examination. If the anomalies are there, so if you are taking radiographs of certain anomalous portions, so whether that is of acquired or congenital, congenital means since birth, so you can easily comment on after a radiological examination. Now, identification of certain things. So I would like to tell you one story that is called a giant stone. So this giant skeleton was more than 7 feet. So John Hunter and William Hunter, these were two brothers. So John Hunter, he was eminent anatomist of 18th century. So they were owning one museum, that is anatomy museum. So this John Hunter requested this giant fellow. The giant means he is having the most heighted fellow in his area, that once you died, you please donate your you can say skeleton to our museum. So this was horrifying to him. So the giant's relative decided not to donate all these things to John Hunter. Then there was secret burial of this giant after his death. However, still it is in the museum till today. It is in the museum of the giant's skeleton was there, but still it is there in the Hunterian Museum. It is still existing. So this giant's museum in John Hunter had identified and see the pituitary fossa of that individual. So it was wide. So it was indicative of pituitary tumor. So it was basically a secretion of certain chemicals or certain hormones which lead to gigantism. So this is one of the, you can say, the clinical correlation with the giant or gigantism. So John Hunter has invented this pituitary tumor in that giants because of this wide pituitary fossa. Then I have also encountered with one of the case where Eagle syndrome. What is this Eagle syndrome? Excessive length of styloid process of the skull. There are various styloid process, but the skull styloid process. So excessive length. So if it is more than 30 mm, so that would be Eagle syndrome, called as Eagle syndrome, and there is little difficulty in swallowing the food, or you can say the speaking and neck movement, because the glossopharyngeal nerve is located over there. So it has been observed because of this Eagle syndrome, unusual movement or abnormal movement may lead to the neck movements would be abnormal as compared to the because of this Eagle syndrome. And one more case I came across with abnormal scapula singularly, the right hand side. Because of this scapula, we commented on the skeletal remains, because this fellow was right-handed, left-handed, so handedness can be decided on the basis. So this fellow was not having the proper movement of right-sided this thing. So when we inquire with the officer, investigating officer IO, so this investigating officer told us that this is basically this was the things, or these were the facts which were there, and in the disease. Okay, so then we gone for the suspects blood relatives for DNA profiling, and it was matched. So mainly the identification is important. So somehow this you can say the anomalies or abnormalities may help to identify the individual even after death. Then the manner of separation. If you see the manner of separation, there are two modes of manner of separation. it could be natural or artificial. So how you are going to identify whether it is natural or artificial? So state of soft tissue, on the basis of state of soft tissues, because certain tendons or certain ligaments, they remain there around a year, around there a year. So if these are in intact condition, so that indicates the natural way. And if it is available, the soft tissue is available with certain marks of bite, cut, or you can say gnawing, that is bite marks of certain animals gnawing, so that indicates artificial separation, because certain animal has separated these bones, for eating the flesh of that individual. So this is again, you will have to identify whether it is natural or artificial. Then the cause of death. So these are the certain points which are in the purview of forensic people. So the cause of death, it is mainly on any injuries, fractures. So we have already seen the pre and post-mortem fracture. Then whether there are any foreign body which are present inside the skeletal remains, that is, bullet, pellets, or any piece of weapons which are present inside, you can say, the skeletal remains. So that indicates the basic things. And here, in some of the cases, chemical analysis for poisoning. So that is again unnatural way of death. So the heavy metals, this is mainly due to heavy metals. So what is this heavy metals? Lead, arsenic, mercury. So these are the slow poisons or the gradual. So once all these, they are accumulated at in the long bones, ends of the long bones. So that is again the chemical analysis. You can identify whether the individual was died due to heavy metal poisoning or not. Then time since death. So it is again, there are three modes of climatic conditions. So what are these three modes of climatic condition? I am in Mumbai. Currently in Mumbai, the climatic conditions are humid. So all around or all over the year, the climatic conditions are humid. So once the death occurs, so that may leads to saponification. So saponification of the body. So Dr. Henal madam is staying in Rajasthan, so where you will get the dry and hot environment. So in that area, once the disease is there, so that would be fixed, and excessive temperature may lead to formation of mummy, that is mummification. And one more condition, that is in Himalayan region. In case of Himalayan region, where you will get intact preservation of the body, so it is easily to identify. So certain fossils, just like fossil of mammoth, it's still with the hairs. So it was observed in um, buried under a very large glaciers. So this is how you can identify the soft tissue if available on the basis of climatic conditions. Then changes due to putrefaction. So there are certain changes if you are getting, because we came across certain skeletal remains where you'll get the putrefaction stage. So that putrefaction stage, maggots are there. So on that basis, we can identify the stage of that time since death. Okay. So just like the putrefaction started, so it is the putrefaction immediately started around 2 to 3 days after the death, but halfway in the conditions like Mumbai, it may start around it may persist till a month. So this is one very important observation. Then carbon dating. So carbon dating is mainly utilized for fossil. So a ratio of C14 and C12. So this is a radioactive isotopes. So all animals and plants, when they are living, they are absorbing this carbon. And once they died, they won't able to absorb furthermore this carbon. So this carbon start on decaying, and this is a radioactive isotope. So on the basis of this content, or actually the availability of this C14 and C12 isotope, one can easily go for the fossil dating, how many years has been passed, or the time since death. Then amino acid content. In case of fresh bones, you'll get 15 amino acid, and after 100 years, you'll get less than 7 amino acids. So this is again content of amino acid, which is very significant. Then nitrogen content. So if you see, so 3.5 to 5 gram percent of nitrogen is up to 50 years, and 2.5 gram of nitrogen persists after 350 years. So again, this will go on decreasing. So on this basis, the experts, they are going to comment on the time since death. So mainly what we have seen, uh, so whenever the report is coming, or the people, police personnel, they are asking us to examine the skeletal remains. So they are asking in the form of this 12 questions. So what are these? What are those? These are the steps what we have seen. Whether it is bone or not. Then whether, if it is bones, whether they are of the human origin or certain other species. Then if the bones are of human origin, what are the names of the bones? So which bones are those? Then again, whether they belongs to one individual or more than one individual. Then what is the age? What is the gender, that is sex of the individual? Then what could be the probable stature of this individual? What could be the race or the ethnic origin? So why this race is important? The race or ethnic origin is important in case of a city like Mumbai, because if you see, there are around, according to some of the authorities, 195 to 197 countries are there. So all representatives at this time, at this moment, they are present in Mumbai, being a economical capital of India. So all these representatives are over here. So you don't know, you are not aware who is going to die, and whether there would be a foul play in the case of disease. So if the foul play is there, so this race would help you, or the ethnic origin would help you, whether the individual belong to which region, which ethnic origin. Then the cause of death. Cause of death, whether it is natural or artificial or unnatural, not artificial, unnatural, natural or unnatural, and the time since death. Then the manner of separation. Manner of separation may be artificial or maybe natural mode of separation, and identification if there are any anomalies. So whenever you are getting, all these things, so this is a combined role of anatomist. So if you see the first 7 points, they are mainly of anatomist: bones, human origin, names, one individual, more individual, age, gender, and stature. So this can be commented by, anatomists. Then the race can be commented by anthropologists. Then, cause of death, time since death, manner of separation, identification, all these remaining 4 points, they are commented by the forensic personnel. So we are practicing at Nair as a whole unit. So being a forensic anatomist, I am in association. Otherwise, the routine practice is the bones, they are sent to in isolation to the anatomy department, or in isolation to the forensic sciences lab, or in isolation to the forensic department to comment. However, we are trying, and ours is the only department in all over India trying such things. And on the basis of this thing, we are getting, a good result in examination. After examination, certain accused were got laid to conviction on this basis of examination. So this is how one has to go stepwise. These are the 12 steps, and then you need not to remember to mention the place of examination and date of examination. One very important thing, why you are going there, because we have been called so many times at crime scene level. So what is our use at crime scene level? The crime scene indicates or tells us basically the identification of the bone at the place itself, and we are guiding to police personnel. Otherwise, police personnel, without knowing anybody's expertise, they are writing, they are getting Manavi hadancha sangada. Then they are identifying just like, mandi che hard, hata che hard, like that. So this is as good as in ACP Pradyumna, in CID ACP Pradyumna immediately ask Inspector Daya, body postmortem ke liye leke jao. They are not the you can say the expert to declare a death, because doctor is the one who is going to declare death. So these personals, we are asking them to identify only the numbers of the skeletal remains, and that too suspected. So it has to be in the form of suspected skeletal remains, and further we are going to analyze or examine the things. So on 3rd of March 2011, around 11:30 a.m., we have received one call from Tardeo police station. So it is because we come under the jurisdiction of this Tardeo police station also. So then we had been visited, we have been called there by the senior PI, and then this was the scenario. This was the scenario which happened over there, because there could be 3 modes of skeleton availability or the skeletal remains availability. So what are these 3 modes? The skeleton could be complete skeleton could be complete male skeleton, complete female skeleton, or multiple skeleton, or the skeleton could be in isolation. Okay, or only certain parts are there. So this was a skeleton of male skeleton, around 25 or 24-year-old fellow. Then we have examined this skeleton in the given form. So we have arranged the bone in anatomical position so that any duplications are there, or the side of the bone. Then this is how we are getting, because this is some administrative part, some clinical part is there for examination, and some administrative part is there, because you will have to take the things in all sealed manner. Otherwise, you are not going to take the parcel for examination from police. It has to be sealed one. So here what he has written Muddemal Manavi Hadancha Sanga, because we have already guided them. So that's why they are keeping it Manavi Hadancha Sanga. It is human skeleton. So this was one of the skeleton where we have encountered only this much part. So this was little difficult. Still, we have reached to the accused. After examination of this skeleton, since it was a complete skeleton, so we were very much sure. So at the 3rd day, the accused were behind the bar. Okay, so this is how we have examined each and every bone, including the small bones also. Carpal tarsals, vertebral column, along with the sacrum. So this is how we are organizing, and this is a combined venture, you can say. This is not a single person's credit, but most of the part is done by anatomist, then certain part is done by forensic people. So here we are doing this thing, and afterwards we are going to again seal the thing and send, and along with the content. This is how the report of examination of skeletal remains we are going to prepare. We are preparing, and I would like to say a proud moment the AIMS team came to our department and saw our, you can say, the presentation at our department, and we were very much appreciated by these AIMS New Delhi people, and they have guaranteed that they are going to copy our report. So this is how we are giving the highlights, whether they are bones, humans, age, average age, okay, the mode of this thing, separation. This is how we are going into the detailed examination. So when additional bones are there, the detailed examination would be done to, the task would be assigned to various people in the team, and then further comment could be, by certain people or certain experts would be taken. So this is written who has discovered or you can say who has labeled these things, and who has name of the doctors and bones assigned for examination. So we are keeping every record whenever there are excess bones. So we need to assemble all these bones in the team of people. So this is how we are providing photographs also and the reports also. Then one more very important portion is remaining. This is the last portion. So what is this? This is called as maceration. So what is this maceration? Maceration indicated. So sometimes the police come to us with not actually the skeleton as such, but maybe along with, you can say, half burned skeleton or some soft tissues are there. So we are keeping them in the maceration tank with, some cow dung or cattle dung is poured inside, and because of this some flies are there. So because of these flies, some larvae or the maggots are there. So maggots eats the flesh and the maceration happens. So and then after drying of these bones, we can examine these bones. So that process is called as maceration. So I extend my thanks to Dr. Hina Sharma ma'am, is head at Geetanjali Medical College and Hospital, Udaypur, Rajasthan, being a chairperson of this session. I would like to thank the organizers, Dr. S.M. Satpute, Principal, APM'S Ayurved College SION, and Dr. Ram Teke, Vice Principal. Then Dr. Jyoti Girigasoi, Head, Department of Rachana Sharir, Dr. Yogesh Gaikar, Assistant Professor, Department of Rachana Sharir. And I would like to extend my sincere thanks to the webinar coordinator, Dr. Arun Dudmal sir, Assistant Principal and Head of the Department of Rog Nidan. Finally, I am thankful to the wonderful audience for your patient listening. Thank you very much.
Thank you, sir. With such a knowledgeable speech. Sir, you said that nowadays it's difficult to get real bones, but I like to share that our students are fortunate to get real bones by our own bone library, which we made from dissected body in our own institute. Thank you. For this session, we are honored to have Dr. Hina Sharma ma'am as a chairperson. Dr. Hina Sharma ma'am is M.B.B.S. M.D. in anatomy. Madam has also done PG/DMCH, advanced course in medical education. Madam is associate professor and acting head of department at Geetanjali Medical College and Hospital, Udaypur, Rajasthan. Madam's 4 publications published in Manual of Histology for medical field as per the latest curriculum-based medical education guidelines. Madam also chaired a poster presentation session on online conference at Anatomy, Avacon 2021. Now I request Dr. Hina Sharma to chair this session and please share your views about this session. Over to ma'am, Dr. Hina Sharma ma'am. Dr. Hina Sharma, ma'am. Hina Sharma, ma'am, over to you. Hello, madam. Hello, hello.
आ गए ना, मैं ये देखना चाहती
Hello, Hina madam. You are now co-host. You can unmute yourself.
Okay. What is it?
Hello. If you are unable to unmute, rejoin you. Left and rejoin.
Hello.
Yes, am I audible now? Am I audible?
Yes, yes, madam.
Okay, okay.
Yes, madam.
So, yeah, I thank the Department of Sharir Rachana of the esteemed APM'S Ayurved Mahavidyalaya SION in Mumbai for inviting me to moderate the session. And the topic taken today was examination of skeletal remains in cases, medico-legal cases. And it was very well presented by Dr.Sumedh G.Sonavane, Associate Professor of the Department of Anatomy in Topiwala National Medical College. Now this session was very informative and it threw light on all the important points of examination. And Dr. Sumedh is very learned and I'm highly impressed and belittled by his achievements. But still, since I've been asked to summarize whatever he has told, I will just tell you the main points of the session. So basically, in a medico-legal case, the thing is that if you get a skeletal remains, that the findings of skeletal remains is actually a very common happening. You keep getting skeletal remains in the forensic department, and usually the anatomists are called upon to examine the remains, and the forensic department also examines them. So although it is always better to for this forensic person or the doctor to examine the bones at the site where they were found, but usually what happens is that the police people and the other public, them in a bundle and brings it to the examining authority to examine it. So this was one of the points that Dr. Sumedh also pointed out, that it is always better for the examiner, doctor to be present at the site where those bones are found, because there are other clues present over there. But even if it is not so, then also using a very systematic process of elimination of all those points that were discussed, if you edit them one by one and do a systematic examination of the bones, then also you can go very close to identifying. So even it is common for the bone never to be identified, and even the death of person dead remains may remain unknown despite all the despite all the efforts of it may be that still this identity of the be possible, but still if you approach it systematically, then it is possible conclusion. And the most important thing to bear in mind is the danger of being too dogmatic. You cannot be very sure, even after you have the bones thoroughly and you have arrived at a conclusion, still you are 100% sure. So you can be dogmatic about it, and especially about the remains. So we should try not to mislead the investigating authorities by these over optimistic opinions, And yet the systematic approach that to identify whether the bones provided to us are actually bones or not. Then the second point was whether they bones only. Then you go on and tell them whether they were human bones or animal bones. So forensic or those of animal. Then the thing, and then you have to identify whether they are of human or not. Then you identify the names of it. Then also you can have to identify how many bodies were there, whether it is of a single person or multiple persons were there, single person or more than one person. And here Dr. Sumedh also told us about a case of identical twin, which you can use to identify whether it is of a single person. UV light and X-ray pattern of the trabecular pattern and X-ray, and the joint, whether the joint fitting is because it is similar in one person and different in different. After identifying if there is more than one body or not, you can identify whether or a female. You know, there are a lot of data available. Usually the bones that are very predictive are the pelvis, skull, and the long, and almost 100% you can tell the gender of the person. And also the stature literature is available where we get a lot of formulae by which you can, so there are a lot of regression calculate the actual stature of the person alive. And then one thing, very nice thing that he said, that we do not use the race word anymore. We always use the word ethnic origin now. So we have to avoid the word race. And in determining the ethnic origin also, there are a lot of indices that are available by which we can identify the ethnic origin of the person, of the deceased. And can also come to a conclusion as to a cause of the death also by skeletal remains if we get any clues, surrounding clues. And then we have to try to, after identifying all that, whether it's the gender and all and the race, we should try to identify the personal identity, give the personal identity to that bone, to those bones. And that is the ultimate actually goal of this thing, whether the bones are of that person or not. So personal identity should also be tried to, you should identify the person, give a personal identity to the person. And so for that also a lot of clues can be given. Clues we can take very surrounding clues also may be there. There may be artifacts that that might be found at the site of where the bones were by the the person. And then in the end, he was also telling all of us that the place and the date of examination should be mentioned in the paper where you are writing. So, approaching this in a very systematic manner, you can identify a lot of, when you get a bundle of bones, whether you have reached the site or whether give a systematic approach and come to a conclusion. So that is all for my son, hardworking, and she's been really persistent and contacted me. And I'm thankful to the college, Ayurved college also, for inviting me to moderate this session. Thank you.
Thank you, ma'am.
Thank you, ma'am, for your valuable guidance. I'm pretty sure that up till now you have enlightened your mind with knowledge and information. Next session is also fixed of knowledge. For second session, I hand over to Dr. Ashok sir, Associate Professor Rachana Sharir, Medico-legal, SION.
Hello. Hello.
Good afternoon, everybody. I myself, Vaidya Yogesh Gaikar, Assistant Professor, Sharir Rachana Department, SION Ayurved Mahavidyalaya. Hello everyone, welcome you all for this second session. I take the privilege today to introduce our next eminent guest speaker, who is my teacher also, Dr. Ashok Jagannath Londe sir, who is presently working as H.O.D and professor at B.Y.Patil School of Ayurved, Navi, Mumbai. He is the student of APM'S and Ayurved College, and also he has completed M.D. from Mumbai University. He has also done diploma in naturopathy from Mahatma Gandhi Mission, Pune, and he has an experience of over 34 years in teaching for UG students and over 17 years for PG students. And he is also a PhD guide. He has attended many national and international conferences of Ayurveda and workshops as a delegate, resource person, and also chaired many scientific sessions. Presently, he is leading as a chairman and a co-chairman on various college committees and one of the university board members. And he has the special interest in to organize and participate medical camps in various places. Also, paintings. He has under his belt 2 group of exhibitions in Jahangir Art Gallery, and also his interest in writing poems and short stories, which are published in Diwali magazines. At present, he is on the editorial board of Ayurvedic peer journals Ayurlog and Ayurline. I now welcome Dr. Ashok Londe sir to please give his valuable words on today's topic, that is clinical application of cardiovascular system. Hand over to you, sir.
Yeah. Thank you, Dr. Yogis. Good morning to all. Actually, it is good afternoon now.
You are not audible.
Audible?
Unmute
your.
audible?
Okay. So, very first, I thank Ayurved Prasarak Mandal, Trustee Board, and Dean for giving me an opportunity to participate this webinar. I also thank Dr.
You are not audible, so please unmute yourself.
सर अनम्यूट है लेकिन माइक काफी दूर है सर, डिस्टेंस ज्यादा है माइक के साथ.
Distance. Okay, now it's okay. Hello.
Yes. Yes.
Hello.
Yeah, you are audible now, sir.
Okay, enough means it is good audible, or means sound is or not, or less. It is okay.
Yes.
Hello.
Hello. Yes, sir, you are audible. Your slide is shared. Now proceed your lecture.
Yes.
Yes, proceed your lecture.
Sir, you are audible. Proceed with your lecture.
Okay. So thank you, Ayurved Prasarak Mandal Trustee Board, Dean, and H.O.D of Ayurvedic, H.O.D of Sharir Rachana Department, Shiva Ayurved Mahavidyalaya, for inviting me and giving, I think it is my privilege to contribute my views in this webinar, this national webinar. This is a clinical application of cardiovascular system. Madam, run होता है, run होत नहीं है, आवाज पण ऐकू येत नाही, आणि ते
Hello.
Yes, yes. Okay. Yes, okay. Okay. Slide. Yes. So clinical application of cardiovascular system.
हॅलो कॉल केला होता स्टुडंटचं काय मीटिंग मध्ये वेबिनार मध्ये हा हो का झालं बघते मी थोड्यात करते बरं ते 11 वाजता चालेल ना बरं नाही तुम्ही ते ह्यांना बोललं होतं ना पोचलाय का 11 वाजता
Participant, please
हा मग ठीक आहे
unmute.
चालेल ओके बाय
It's okay. This is a Hridaya. It is having a very special meaning, and this Hridaya is this etymology of the Hridaya is there are three words or by shabda, that is a ru, then the and ya. So here ru means haranam. Haranam means receiving. Da means giving, dana, and ya means ya is yana is continuous working. So this is the meaning of the hridaya. That is the organ which actually receives, gives, and this process is going throughout our life. And this process begins very early in the stage, around fifth week of the conception. Utpatti, that is a developmental anatomy of the heart, is it is made up from it is compared with the inverted lotus bud. It is site for Chetana, then Mana, and a Para-Oja. It is also included in a Koshtanga. It is a Koshtanga means it is a thoraco-abdominal viscera. Included in a Dasha Pranayatani. There are the 10, those described in the Ayurveda. There are pathways of life or Jivita Dhamma. So that is included in the Dasha Pranayatani. And Shruta Sambandha wise, it is a Moolasthana or roots of a Pranavaha Shrotas or respiratory system, Rasavaha Shrotas or channel of the body fluid. Dosha Sambandha, it is site of Vyanavayu, Avalamba Kapha, and Sadhaka Pitta. Dhatu Sambandha, site of Rasa Dhatu, Rakta Dhatu, and Mamsa Dhatu. Marma Sambandha, it is a vital area. Wise, there are, as described in the Ayurveda, this is a vital, one of the vital marma, or Sadhya Pranar marma, Sirina marma, and included in a pre-marma. The general anatomy of heart. This is a very structure-wise, it looks like a lotus bud, and here the major vasculature, which already the large vessels, which large vessel which is connected, or can see upper side, that is a aortic arch, then left pulmonary artery, here on the superior vena cava, right atrium, right auricle, this is the right ventricle, and the left ventricle, which is very basic structure wise. Then pericardium, this is a pericardium, this here. Actually, this pericardial fluid itself is a, we consider as a avalambak. This is a fibrous pericardium, serous pericardium, parietal pericardium, and visceral pericardium. The blood supply of pericardium is pericardiophrenik artery, internal thoracic artery, musculophrenic artery, thoracic aorta, and innervation by the phrenic nerve. The location of heart. It is in the thoracic cavity, extended from the second to fifth intercostal space. It has a right border, left border, inferior border, and the superior border. Exterior of the heart here, the similar diagram I have just shown you. There is only one structure as very important. This is called as a, and in this diagram, this is a ligamentum arteriosum. Okay, because I am supposed to talk about these vessels and the chambers of the heart. This is important because every structure which we can see here on the screen, this structure, like a right atrium or right ventricle, left atrium, left ventricle, then tricuspid wall, bicuspid wall, this pulmonary wall, and here just behind is a aortic semilunar walls. Now all these structures which has developed, every structure is normal. As far as it is normal, there is no problem. But the structure which is okay, the structure definitely which develop in the fetal life, if it is not normal, that means every structure which we can see can be abnormal. This is what I am saying. And this is a basic structure of right atrium, and this is an internal structure. It consists of posterior smooth part known as a sinus venerum, and anterior rough part is a atrium proper. This rough part, this pectini, and this is a smooth part. This actually, the rough part, helpful to reduce the pressure of the blood or the stroke of the blood when it enters into the right atrium. Then it is a right ventricle. This is what I am just giving now. Then it's okay. Hello. Now, is audible? Hello. No, audible. Am I audible?
Yes, you are audible.
Sachin. Okay. So it is necessary. So this, everybody knows this anatomy, frankly speaking. But I'm just revising it just to, because I'm supposed to talk in detail about this. then left atrium, okay, where you get the two pulmonary veins open into it. Some part of it is this musculopectin is there, and the most of the part is a smooth. And the special one thing here, it is a left auricle. It is a sac-like thing, around 1 inch in length. But this is a area where actually works as a reservoir to the left atrium, because when the blood comes from the liver, from the lungs, and it accumulates for the time being till it enters into the left ventricle. So thus the most part of the atrium is a smooth wall, and musculopectin is present in the auricle. This is the left ventricle, the left atrium, left ventricle. Next, these are the walls of the heart. This is aorta, this is aortic wall, left atrium, left ventricle, and this is a right ventricle. Now, this is the normal aperture or opening of the aortic wall, and when it is closed, how it comes into these margins, they come to each other and they seal the lumen. See here, it is just again one picture. It is diagrammatically it was shown. Now you can see it is here. It is a tricuspid wall. It is a mitral wall, but it is taken from the above. Here, this is a pulmonary wall, aortic wall, tricuspid wall, and the mitral wall. That artery, the supply is to the heart is the two major arteries. That is one is supplied by the right and left coronary arteries. They arise from the aorta, and these coronary arteries, while giving lot of branches, it actually surrounds the heart area and supplies to the underlying tissue. So this is a picture where you can see how it coronary artery comes from here, one on side and the right side, and these are the branches. So this is just to show how and how much area is supplied to the musculature of the heart. This is a venous drainage of the heart, where you get the one large structure, a continuation of the great cardiac vein, and that becomes a coronary sinus. Other structures, this is a small cardiac vein, middle cardiac vein, great cardiac vein, and these veins, they open ultimately into the right atrium. So this is how the superior vena cava, this superior vena cava is a great cardiac vein. This is just a diagram similar, just showing the venous structure around the heart. Now supply of the heart. You know, there are two important nerves, sympathetic and parasympathetic. Here you get the sympathetic supply through the T1, T2, T3, T4, T5, and the vagus nerve supplies as a parasympathetic nerve. And this supply goes to the SA node and a AV node. The wall of the heart, when you take the or when you take the flesh, or when you check the some part of the heart, there you get the three layers on it. One is the epicardium. Epi itself means upper portion. Then the myocardium, means the musculature, obviously, and endocardium is the inner structure. The conduction system of the heart. Why we need conduction? And this conduction, which actually helps to beat the heart, This is a sinoatrial nerve. It is this node initiates or ignites the first current, and the current is passed to the septum area, and there is another the current goes to the atrioventricular node, and from here, when it starts contraction, the blood goes to the all over body. Now, as these structures are there, and they are very much helpful to your blood flow, anything can happen to the sinoatrial node or the AV node. And so if the current doesn't come from the upper side to the lower side, the function of the heart will be hampered, and it will hamper very bad way. So now let us come to our original or very coarse portion, and that is a cardiovascular diseases. See, as I told you, as there is a part, there is a normality. As far as we don't look at normality, because when it is normal, nobody looks at. But when there is some problem, then definitely we look at it, and we very much worried about it because of the problem to that person, or when the function goes wrong, then only we think about that structure. And here, the problem with the heart, Michael Phelps says, the problem with the heart disease is that the first symptom is often fatal. Now, why this of the first symptom itself is often fatal? The reason is mostly we don't care of the symptom. Once you understood it, there is some problem. Till date, until that particular time, maybe lot of problem, because the attention is not given. And when the symptom you notice, that time there must be some problem, because every symptom, if it is not treated, leads to the death. And that is why one must care this beating of the heart. Now, what are the cardiovascular diseases? There are many diseases. Now, as there is a structure, it has an abnormality also. That totally depends on the embryological development. The heart disease, let us read this. Heart disease describes a range of conditions that affect your heart. Heart disease include the heart defects, as I told you, congenital heart defect, the blood vessel disease, that's those mostly we call it as a CAD or coronary artery disease. Then there's some problem, as I told you, there is some problem with the rhythms. So rhythmic problem, that the rhythms is totally dependent on SI node and AV node. Then structural, again this heart wall problem, so we call it the valvular disease. Then this musculature problem, and the one which is heart infection. Now let us start with the congenital heart diseases. Actually, before going to the congenital disease, we should, as I have made this, there are the types. There are two types. One is congenital heart disease defects. Now, this congenital heart defects, when I'm talking about the anatomy, I usually said not disease, but the defects, because it is a defect in the structure. And the heart irregularities that are present at birth. So congenital is related to birth. Acquired heart disease, these are irregularities that are present after birth. There are due to many, there are very different reasons. One of the reasons is right now is corona. That also affects the heart. Now let us come with the congenital anomalies of heart. So these are the defects which are there since birth, and that these defects occur while the development of the heart. The first is septal defect, that is a patent fossa ovalis. That is a septal defect. That's I told you, I've shown you many parts. Similarly, this every part is having its own disease or defect. Atrial septal defect. So we are going to discuss all this. Ventricular septal defect, then complete atrioventricular canal defect, wall defect, then the stenosis or irregulations, regurgitation, and atresia. Atresia is where the lumen itself is a narrow or maldeveloped, we can say. Then patent ductus arteriosus, truncus arteriosus, Ipstein anomaly, teratology of Fallot, dextrocardia, and ectopia corpus. Okay, so let us see the atrial septal defect. Now this is usually very common. As the septum develops and makes 4 parts. First, it makes the right and left, and then other parts means. So you get the chambers like upper and lower chambers. So this one is a very important. Is an atrial septal defect because here within the let us check here the left atrium and right atrium. And there is a one structure which develops and it has a disc-like shape that is called as a fossa ovalis. And as there is this septum comes and meet from the upper and lower side, just the defect may occur there. The defect is nothing but the usually there is a small foramen, and that foramen from 1 millimeter to the maybe up to the centimeters, and the defect remains as a afterbirth, because in the embryological life we need to have this right atrium and the left atrium open, because there is no use of left ventricle sending the blood to the lungs, because lungs do not work that time, and hence because the blood which comes to the embryo, or we call it embryo, we take it as a fetus also, the blood itself is oxygenated. So, and the lungs are useless that time or non-functioning. So naturally, the blood which is comes to the right atrium doesn't require to pass into the left right ventricle. So at this atrioventricular wall is of no use or not working. So the blood which is coming from the right atrium is supposed to go to the left atrium directly, because from here it has to go to the all body, and hence this portion is naturally kept open for this stunt from the right to left side, or the flow actually from right to left side. Understood? So this, as after birth, as the original system takes over, that means the lungs started or inflates and starts the taking the oxygen which is required, then that time this fossa ovalis or the foramen that gets closed, and the blood which comes from the right atrium goes to the right ventricle, and this goes to the pulmonary trunk and to the lungs. So an atrial septal defect is a hole between the two atria, the hole or maybe very small opening. Okay, so this one is a very common because the defect usually remains maybe up to 2 months for the complete closure of this area or septum. Then, as we have seen the atrial, same there is a ventricular septal defect. Now, this is, see, ventricular septal defect is an abnormal opening in the wall. This abnormal opening in the wall between the two ventricles. Now, this is not the same as the fossa ovalis. Now, this is something, the problem with the ventricular septum itself. And so what happens, the blood which is into the left ventricle that goes into the right ventricle, and so it is called as a left shunt, for a left to right shunt. So it is you can take it as a something like a fossa ovalis, where the fossa ovalis, you take the blood flow is from the right to left side into the atrium, and here it is the blood comes from the left ventricle to the right ventricle. And so this defect is also every defect, not only this defect, every defect in the heart, if is not treated surgically, or if it doesn't come or close in the natural way, the life itself is very miserable. So now, this is a complete atrioventricular canal defect. Now, this atrioventricular canal defect is what it shows. There is a problem. It is not between only the atrium. It is related to the whole structure or whole septum, which makes the right and the left area of the structure. So here it is. It's a normal. Okay, and see what is happened here. There is a only common wall, and so there is all blood is mixed together, and that is atrioventricular cord or endocardial cushion. This is called the endocardial cushion defect, because this cushion, which is supposed to develop in the embryological life, it has not developed, and hence the septum is not developed, and hence what happened? These upper and lower chambers remain connected to each other. This is also rare, but one must. I told you, this is one structure while showing this normal structure of the heart, that there is one structure I shown, that was ligament ductus, as this is a ductus arteriosus, that is ligament. I shown you there ligament. Now, what is meant by ductus arteriosus? Ductus, you know that this is a meaning simple duct, and now this is arteriosus because it has come from or it is a connection between the connection formed from the pulmonary artery. Now, why this? First of all, why this connection is there? As I told you, the lungs are non-functioning. Naturally, if the lungs are non-functioning, the oxygenated blood is not necessarily required to go to the lungs. Now, what happens? There is a shortcut. That shortcut comes means the pulmonary trunk is not getting the blood that time, because 90 to 95% blood from the right atrium goes to the left atrium, and from the left atrium it goes to the left ventricle, and from the left ventricle it goes to the in the body. But the blood which, while beating the heart, as I told you, the heartbeat starts from you can say from the 3 to 5th weeks of the conception life. So very early stage, the heart pumping starts. Now problem comes with this. Some portion of the blood which is required or leakage while the pumping the heart in the embryological life, and even that is one of the requirements, some blood which comes from the right at this tricuspid or from the right atrium to the left, right atrium to the right ventricle, some blood that is which is leakage, actually you can say, that goes towards the pulmonary trunk, pulmonary artery, and this pulmonary artery, the blood is not, as I told you, the blood is not necessarily required to the lungs to go. So what will happen? The blood will go directly into the aorta. So whatever while pumping and the blood comes from the right atrium to the right ventricle, that goes to the pulmonary artery, and that goes to the ductus arteriosus, and that goes into the aorta. Now the problem comes with this. If this remains a patent. Patent is a working. So if it remains open, the problem will come. The blood is supposed to go from pulmonary artery after birth. Now I am talking about after birth. When the blood comes from the pulmonary artery and going to the supposed to go and it goes to the lungs, but if it remains patent, patent means working. So what will happen as the blood will go to the lungs, the blood will, that is in the after age, after the birth, there is a blood which is deoxygenated on the right side. So deoxygenated blood will pass into the aorta, that means in the oxygenated blood, and this can be easily we can diagnose this, no issues, because this can the baby will show some blue lips or nails sometimes when it breathes or cries, that can occur. Okay, so patent, but this patent ductus arteriosus can be locked here, can be ligate here, and this can be, see here. And ligation is a very simple procedure that can be that can cause. Okay, so here this impure blood will go into the aorta. Here it is shown. Then the truncus arteriosus. Now this truncus arteriosus is very embryologically, you know, the bulb is formed after formation of the two tubes, and after the distal portion of the bulbous cordis continues as a truncus arteriosus, and this truncus arteriosus divides into two and forms the and goes on the opposite side. So right sided part goes on the left side, the tube, and the left sided part goes on the right side. And there you find this, and in the later development you get this as a pulmonary artery, and one you get as a aorta. If the truncus arteriosus, if there is a defect in the truncus arteriosus, is supposed to divide into two. If it is not divided right and left side, what will happen? This continues. They will, if it remains as a continuous in the later stage, this will be having the one opening of this pulmonary artery also and the aorta also. And there is a definitely there is a ventricular septal defect also because of this maldevelopment of the aorta and the pulmonary trunk or pulmonary artery, can say. So this is again a very huge heart defect. Now let us come to these are that I just explained. These are where embryological defects. Now valvular defects are somewhat maybe congenital. There are many other congenital diseases also, and can be in the later stage also. So let us see what is this. What is this? This is a normal aortic wall. See, once the stenosis occurs, see what happened. This wall is supposed to, here you look on this side. What happens? This is closed. It is completely closed. All the borders, they are approximated correctly. But here you see this is the area which is remain. Now what will happen? Definitely what the function of the wall is hampered. It is supposed to close, that remains open. So what will happen? Leakage of the blood or fluid, or here it's the blood only, maybe on the, see, once the stenosis occur, this is the how, because once it is stenosed, this way they will close. So there will remains, once the stenosis occurs, this it is really very less helping to closure. And there is the leakage, maybe we can call it the regurgitation. That I will explain next afterwards. Now, what are these are valvular defects? Now, this already we have seen one, the stenosis, where there is a hardening of the walls and they do not meet or they do not approximate in the closure time. And what happens? This stenosis goes to the regurgitation. Just I told you, regurgitate. Regurgitate means there is a opposite flow. Opposite flow means the blood which is supposed to go upwards in the pulmonary trunk or pulmonary artery, if there is a stenosis here, the regurgitation will be take place. So blood will come on the blood will come on the that is a backflow. Okay, so this is a backflow. So stenosis, the stenosis gives you backflow or regurgitation. This one since anomaly, this also embryological problem. See, it is very, will not read all this. The simple thing is there is a maldevelopment of the right atrioventricular wall. Now, if the wall is not developed properly, there is an enlargement of the, because of this, there is an enlargement of the right atria and there is a very less or a very small area of the right ventricle. Then tetralogy of Fallot. You know the tetralogy stands for the number 4. Okay, that means tetra means 4. So this tetralogy of Fallot is a name. Sometimes it is also called as a Fallot's tetralogy. So these are the four defects at a time. So that is called tetralogy. Now, one defect is narrowing of the pulmonary wall. So tetralogy, there must be 4 defects. So we'll count here. One is narrowing of the pulmonary wall. Then see, thickening of wall of right ventricle. So this another defect. Third defect, displacement of aorta over ventricular septal defect. So this is another defect. See what happened? It is displaced and even the septal defect also. And the fourth one is ventricular septal defect. So this narrowing of pulmonary trunk, thickening of right ventricle, aortic displacement, and the fourth one is ventricular septal defect. So this is called as a Fallot's tetralogy or tetralogy of Fallot's. Sorry. Now comes the ectopia cordis. Ectopia itself is displaced. Now what is displaced here is ectopia cordis. Heart is supposed to be there inside the chest cage. Here, the heart is out of the chest cage because the problem comes with not only the heart, but there is 2 plates of the sternum. They are supposed to come as the fetal develops. Then, and these 2 plates of the sternum, they come together and they form the one body of the sternum. But when it fails, the sternum remains open, and by that time, as the pulsation starts, then it becomes more of the difficulty for the sternum to unite, and the heart itself will come or remain outside. But now so many modalities and surgical procedures, high-tech surgeries can save the baby. It's very possible. Now you know this dextro, which is opposite to the sinister. Dextro means opposite to sinister. Sinister is left, then dextro means right. So this is dextrocardia. Now dextrocardia is what? That this is a normal position of the heart. This is a dextrocardia. See, the other structures are there, but the apex is supposed to be here, somewhere in the fifth intercostal space. It is on this side. So it is a twist, and the vessels are on the posterior side. So, there is not a great problem to the baby after the adult life, in the adult life also, because that is the only position of the heart is changed from the right to the left side. The vasculature is normal, but even it is said that when it comes the dexter side, so many other structures which are on the left side, they may appear on the left side. They may develop into the opposite side. That means if the spleen is on the left side, that might be, or that may be there on the right side, similar to the liver also. Now let us go to the acquired heart disease. Now acquired means, now we have seen the most of the, not all the, because there are genetic disorders also, then some disorders in the congenital life due to the some enzymes also, that I have not considered right now. So this acquired heart diseases. First start with the arrhythmia. Now in a short, arrhythmia is where the rhythm is lost or abnormality of the rhythm. Atherosclerosis is hardening of the vessels or mostly arteries. Then CAD, as we know, this is a coronary artery defect or disease, is caused by the buildup of plaque. Now plaque is developed mostly, we'll see in the diagram. Look, okay, let us see the diagram itself. No, it was not there. So plaque is maybe usually your platelets or your blood clot, you can say, and most of the times the fat within the lumen of the artery. And then cardiomyopathy, this condition causes the heart's muscle harden to grow or grow weak. Harden or grow weak means they become weak. Then heart infections, there are, you know, that there are infections. This may be bacterial, maybe virus, maybe parasitic. Now we'll just check what happens. We are not going into the bacteriology or viruses or virology or parasitology. Then cardiac tamponade. This is one, but this is also rare condition. This cardiac tamponade is a pressure on the heart from the outside. Now what is the outside? That is the pericardial fluid. Okay, and the space, this fluid build up in the space between the heart muscle and the outer covering. With that covering is nothing but the pericardium, and that gives the pressure. That I will show the diagram and how it happens. Now what comes the first? The arrhythmias. This is an improper beating. Now this is a very normal beating here on my screen. So improper beating of the heart, whether irregular, too fast or too slow, anything. So you know that this term. So let us go to the next. But when there is there may be too early, premature contraction. On the ECG, you can say this premature this VP beats also, and this fibrillation, the too erratically. It is like a fibril, like a fiber. When there are many fibers, you see vibrating similarly. Similarly, the so many structures of this, you feel like the arrhythmia is very in a different way. This is when an arrhythmia interferes with the blood flow to your body, it can damage. Definitely, now it is nothing to say about this. That is always there. Okay. Now the arrhythmia causes, as we have seen, the arrhythmia causes due to the some problem with the conduction system. Conduction system, we can call it as a as I told you, the concepts or principles related to the heart and the Ayurveda. So Vanvayu, which we are talking, which flows the contributes to send everything to the body, that Vanvayu. And here I take the Vanvayu with I consider this as a conduction system of the heart actually helps to send the blood to all over the body. So, and the van does the same. So here the color is shown and the waves are shown. Now this wave, so this P wave starts when there is a first ignition, we can say, or the first current takes place there in the sinoatrial node. See here, now we'll go to the back. Here, from sinoatrial node to the AV node. Now you know that this structure is showing the current. This current, now as the current is required to pass from the right atrium towards from the right atrium on the upper side, the sinoatrial node passes the current to the AV node. Then AV node, from there it passes to the bundle, and from there it goes to the left side and the right side. Now the current, as current pass, we can see how it shows how the current is passed. Now this shows the contraction. You see up to the P wave and the R wave. So P wave there starts from the sinoatrial node. So P wave indicates the conduction from the or within the right atrium, or the conduction started from there and reaches to the AV node. And from there, AV node, as soon as the current passes into the septum, it goes from the left to the left side and then left to the right side. And as it gets charged up to the contraction, this takes place. And as it relaxes, there is starts the T wave. So you should know only the this depolarization and the polarization. So depolarization, remember the word itself, it means that is a contraction of the heart. That's all. Okay. And so, and repolarization means relaxation of the heart. So T wave indicates the relaxation of the ventricles, and this shows the contraction. So contraction and the relaxation. Okay. So I think it is enough, because we can discuss this physiology right now in the detail. So this is a sinus rhythm. What is a sinus rhythm? That is a sinus. So sinus rhythm is sinoatrial node. From there, the conduction is started. So that is a sinoatrial rhythm. So this shows the P. This is a Q, R, S, ST segment, and this is a T. So this is normal. Now this is occupies. Now we are not going into. So okay, fine. So this is a normal nodal rhythm. Even I am not going to discuss all this. How these are P, but there is no QRS complex. So this in the atrial frontal, just check. And this is a ventricular fibrillation when there is no waves can be seen, but it is just like a wave. So here is the atrial fibrillation. there are many P waves. Okay, if you check in the atrial flutter, there are few, but in the atrial fibrillation, there are many. So flutter, it is somewhat the bird is flying, so the wings, how you can check. But can you check how many fibers are there in that wings? If you connect the fibers, you cannot count that. Similarly, here you can't count the P waves. Okay, next. Now comes conduction as the disease or the system, that is a conduction system, and anything wrong with the P wave, or if you check on the ECG, if it is a P wave less or more enlarged or more than number, then there is a definite time from the P wave to start the Q wave. So the length of the P to Q wave, that also indicates some deformity. From Q wave starts the QRS complex. So that is the particularly contraction of the heart, and that is what we always check the QRS complex. Understood? Because T is a relaxed in the repolarization state. So the T wave indicates if there is some wrong goes with the relaxation of the heart. So T may be flat, T may be enlarged, T may be inverted. Okay, so that is what we are talking about, the conduction system of the heart. Now let us see the another deformity or a disease. Now we are saying, can say very well, I can say it is a disease, not anatomical description. So comes the atherosclerosis. Already a definition was there in the first few PPTs. What is atherosclerosis? It is a simply hardening within the arteries. Now just check the lumen, see what is happening. So in the progressive stage, and then comes the blood clot. I think this atherosclerosis everybody knows, and we are not going to discuss about why and how. We are just checking the vascular disease. This is a coronary artery disease, or CAD, or CHD. This ischemic heart disease, or simply heart disease, involves the reduction of blood flow to the heart muscle due to buildup of plaque. Or that is a plaque. Already I told you that is a plaque, not necessarily of a blood clot. It may be fat. Okay, so this is a healthy artery. See, initially this beginning of the deposition, then partial, this plaque is there, and then near complete blood. Now this is as the plaque we have discussed, the plaque may be anywhere in the body, or mostly within the plaque developed within the coronary arteries. As far as there is a good pressure and as far as the lumen is enough, the blood flow is continued and there is no problem, or the symptom is hidden. The patient may not understand the problem, what is with him, because it is bearable, we can say. And when it goes beyond that, then that is the first symptom, which I told you in the very first slide, that becomes a fatal. So here, just check the diagram, because everybody has to go for the lunch also. I know that. I will finish it fast. Okay. So this coronary artery, it is a block. See, it is shown in the diagram. Okay. Blocked blood flow. So what will happen? This blood is flowing on this side. The plaque is somewhere here. So not allowing to pass the blood here. So the blood goes on this side, and this will be the less of the oxygen. The time, what will happen? Necrosis or the dead tissue. what will happen? We'll get the dead tissue. And so this particular fibers of the heart, they will never beat. They will die forever. And so we have the golden hour to get this treatment. Okay, now understood. So this is the normal cardiac muscle or heart muscle, and how it's shown here, it is discoloration. Now this is aneurysm. This aneurysm can be anywhere, not necessarily related to the aorta. This may occur in the thoracic aorta, maybe into the abdominal aorta, and even there is a dissecting aneurysm also. So dissecting aneurysm is a very large, where the aneurysm is continuous to the long area of the vessel. So we are talking about this diagram only, which is related to the heart. So this is a aortic aneurysm. Okay, so there is a dilatation of the heart, dilatation of the vessel, and maybe usually what I am saying is the dilatation of the coronary walls. So there are coronary what walls are there? So not coronary artery walls. What walls? The same there in the what we get the arteries. Every artery has got the 3 walls. Okay, so there I am talking about WALL. Now, coarctation of aorta. So as we have seen, it is exactly opposite to the aneurysm. Now, in the aneurysm, we have seen this dilatation of the aorta or the aortic wall, and here we see the. Can you see? This is the actually this is supposed to be the mark of this aorta, but see here what happened. There is a very small area, so there is a somewhat narrowing of the lumen of the aorta. Now let us come to the heart infections. So the infection, whatever the infection is occur anywhere in the body, can occur anywhere can occur in the heart. Now what is this? This heart infections occur when an irritant such as actually every foreign material is irritating. So bacteria, virus, or parasites, or a chemical reaches heart your muscle. An infection can cause, this is a very simple thing, can cause inflammation or a damage to your heart's inner lining. So inner lining of the heart is nothing but the endothelial lining. So endothelial lining, which we talk about, is usually about the arteries, but the endothelial lining is the same there in the heart also. So you must know this. So endothelial lining is very delicate lining, and so the infection will give you the irritation. Irritation will give you the inflammation, and inflammation will give you the infection. So that are the process of the disease, we can say. Now, what are the heart infections here? Actually, it is just which is related to the heart. So we are talking about so I am here, I have taken the pericarditis. So now the definition itself is enough. We can't go on discussing the disease here. The swelling and irritation of the pericardium. All you are listening, hello? Can you hear me? Let me check. Am I audible? Sachin?
Yes, sir.
Okay, thank you. So I was not, I was thinking everybody is sitting or not listening. So pericarditis, we are not going to discuss the disease. We are just checking the what happens to the heart and what happens to the vasculature of the heart. Okay, understood? So here, the swelling and irritation of the pericardium. So it is on the outside. So that the tamponade, the word I just showed you, the tamponade is there inside this PPT also. I will show you. Okay, what is this? Endocarditis. Now this is a pericarditis. This is a pericarditis. Now endocarditis is an infection of the heart walls or inner lining. So the endocardium is in inner wall, which is endothelium. So damage heart walls. Any infection anywhere in the body will damage. That's all. Then myocarditis is related with the inflammation of the musculature. So this one. Then comes this cardiomyopathy. How it goes ahead? Okay, next comes the cardiomyopathy. Okay, the cardiomyopathy is what? Cardio is a heart and myopathy means muscle. So that is what some problem with the muscle. Now what is this? The type of progressive heart disease. Okay, because inflammation of the heart is not a progressive heart disease. Understood? Because that is on of a sudden. As soon as the infection took a place there, the heart gets the problem. But the cardiomyopathy, when the condition remains for a longer time, or you can see the chronically, so then the heart muscle will show the this enlargement. There is abnormal enlargement, somewhat thickening, and even it may be stiffened or hard. Okay, and definitely the ability of the pumping of the blood will lessen, and there will be less blood to the body, and even the backup will be less. And so that when the blood supply itself is having problem, so definitely there will be abnormal heart rhythm. So there are many actually, but this is these are the basically you must know. So what is meant by dilated cardiopathy? So dilated cardiopathy here, you may get this some storage within the heart walls. Maybe like amyloid. That may be there in this. I will discuss. Maybe some like iron, or you can say metabolites. So that can, even some chemicals also can cause this. So dilated, where there is a dilatation. Ischemic cardiomyopathy, because there is a less blood supply, so the cardiomyopathy took place. Then the restrictive cardiomyopathy, because it was not properly constructed. So these are the diagrams. So now what you can see here, this is a normal. Okay, just check here, because I will show you all the PPTs, but it's little fast. So this is a thickened ventricular septum and even the thickened left ventricular wall. Now this is a natural, we know. If you compare to this upper chambers, the ventricular walls are thickened or thick. Why? Because they are supposed to contract, and so they are always large. But in the cardiomyopathy, this is more than normal. See, this is a normal, so it is more than normal, just for the comparison. Yeah, see that I was talking about. So we are not discussing this. We should know this. There are many diseases, even the this just genetic, then mixed. So that time there is a dilated and restricted. In these both, there is a less blood supply to the body. Then acquired, that is inflammatory, bacterial, Tocosus cardiomyopathy, and peripartum. It is when it's just near after the birth. Okay, so it's the partum and the peripartum. So after the birth, the weakened walls of the heart. Then secondary, there is this secondary is a Furby's. Furby's disease, hemochromatosis, Here the iron is more infiltrative, where there is a lot of protein and this fat within the heart walls. Okay. So this is a cardiac tamponade. Now cardiac tamponade, this, see the buildup of blood or anything when I'm saying it is a buildup of a blood or other fluid. Now other fluid is nothing but pericardial fluid itself, maybe more if it is a pericarditis. And so what will happen if it is a more build up within the pericardial sac? If it is more, what will happen? This will increase in size, the pericardial size will increase, and heart will just not move, but it will just like a what do you call it, float in within this. And the heart in the radiological appearance, it will be like a that's called as a globular heart. It is like a bulb inside the water. Now let us start with the radiological examinations. See, I have few radiographs to check you. See, right atrial enlargement. Now you know this is supposed to be this area supposed to be 1/3 of the chest cage or the here at the base. So when there is a more, this is a normal actually. So this area occupied by the base here in the radiological base I am talking, this much area or maximum to maximum here up to the apex is supposed to be 1/3 of the diameter of this thoracic cage in the radiograph. So it is very clear the heart is okay. It is equal somewhat because it is less here, it is more here. So it is a 1/3. Okay, check here. Now what happened? It is okay. It is a aortic knuckle, you can see. The left border, you can see. Apex, you can see. But what is this? This is the nothing but the right atrial enlargement. Okay. So let us check the next. Okay. Fine. Now left ventricular enlargement. See atrium. Yeah, it is another, sorry, the left will come here afterwards. See here, it looks like a boot. Usually on the radiologically, this shows like this boot. So this is this is the right atrium enlarged. The left nuchal is visible. So as far as the nuchal is there, the left ventricle is normal. This is a very simple way to diagnose on the radiologically. Okay. Now left atrial enlargement, and we have seen this enlargement on this side, this much on this side. It was looking like a boot. Now here it is a left atrial enlargement. See the aortic nuchal and this enlargement, because the left atrium is a very less visible on the radiological view, but the left ventricle is maximum visible, and the what we can see is only aortic nuchal and the small area. But here you can see the wave-like structure, 1, 2, and again here. So this upper area is a left atrium, and so if you can see this, the left atrium is this is left atrial enlargement. But if we can check the left ventricle, and even here it is, we can say a little bit of right sided enlargement also, but it may be compensatory. Compensatory means if there is a defect on the left side, may defect come on the right side also. Okay, and that compensatory defect I will talk on that for 1 minute. Oh, this one gone. Okay. Yeah, this is last. This is the last left ventricular enlargement. Now let us check the first or second PPT, where I have shown you the right atrium, right ventricle, left atrium, left ventricle, tricuspid wall, bicuspid wall. Then here it was a pulmonary trunk, then the pulmonary walls, and here aortic opening and aortic walls, and this. Now let us just that I was talking about the compensatory defects. Now, the first of all, you know, the venous blood comes into the right atrium, and so the first structure is in the right side is the right atrium. But if there is a problem with the right-sided defect, or we call it it's a right wall, that is atrioventricular wall, is a tricuspid wall. If there is a defect in the tricuspid wall, what will happen? The blood will not pass into the sorry, no, I'm talking because how it okay, just check. So what I was telling is the right atrium. So right atrium is filled with the blood. What will happen? The will regurgitate. So what will happen? The blood which is there in the right atrium, that will flow backwards. Now what backward means? That will be there in the, that will go in the inferior vena cava, and from the inferior vena cava, that will pass very early, very first organ, large organ is the liver. And so there you may get the congestion in the liver when there is a problem with the right tricuspid wall. Okay, and definitely you will find the right atrial enlargement. Suppose this is what the simple radiological diagnosis. Now, if you say the right ventricular enlargement, that means the blood which is supposed to go further into the pulmonary trunk, that is not going properly. That means if there is a problem with the pulmonary trunk, what will happen? The blood which is going from the right ventricle to the lungs through the pulmonary walls, if the walls are regurgitating, or with the stenosis, or the blood reverse flow will be there into the right ventricle. And what will happen? The right ventricle will enlarge. And again, if the right ventricle will enlarge, that will be definitely give some problem to the tricuspid wall, and hence the some blood may pass into the right atrium also. So this is what we compensatory changes in the heart sizes. If there is a problem with the heart or lungs, and if there is any disease, what will happen? The blood which comes from the lungs to the say this left ventricle, okay, ventricle, anything, if it blood comes extra, if the breathing is fast, what will happen? The right atrium will fill with the blood. Similarly, some portion, and usually some portion of the blood that goes just for the time being of the before the contraction of the heart, the 1 inch portion which is there into the left atrium, that I told you is a auricle, which is a hollow, and the blood will remain inside the this auricle of the left atrium. And so this is one problem. Some, when there is an open heart surgery, they do. What happens, you know, sometimes they forget to remove the blood which is there into the left auricle, and the person dies after the successful operation because the blood clot remains there. So if now let us from the left atrium, we are coming to the left atrioventricular wall, that is a bicuspid wall or a mitral wall. Suppose there is a stenosis of the mitral wall, what will happen? The blood from the left atrium, which is supposed to go to the left ventricle, is not passing into the left ventricle, that will remain inside the left atrium, and so you will get the left atrial enlargement, and the stenosis of this will of the mitral wall is very common, and that is very chronic this disease, that is a rheumatic fever, we say. And so left ventricle, if there is maybe an enlargement of the left ventricle, is very simple. Check the which further structure is, that is aorta. And if aortic valvular stenosis is there, what will happen? The blood from the left ventricle supposed to go into the aorta through the walls. If the walls are stenosed, the blood will remain into the left ventricle, and after some period of time, this left ventricle, due to the accumulation of the blood, may get the myopathy also, and you may get, the radiologically, you get the enlargement of the left ventricle. And so next point is, what is the auscultation, and why auscultation is done on these areas only? Why? Actually, anatomical structure wise, if you take the surface anatomy, this is something funny, you will say. See, this is the sternum. In the embryologically, we have these two plates, and just because of this opening, ectopic cardiac deformity occurs. So what is this? This is the aortic area. Remember, second right intercostal space. Now you will say the aorta is there into the left vein, originates from the left ventricle, and from here it goes from here to here. And auscultation, good auscultation, that means points of auscultation itself means that is a particular area or the best possible sound you will get here of the aorta on the right side. Now how it comes on the right side? Because this, as it goes straight here, and but here from here it changes the course of this aorta changes the course, and so the turbulence comes on this area, and so here you get the clear sound. Similar thing into the right side and this intercostal space. Similarly, all the sounds now you get on the lateral border of the sternum. Why? It is a pulmonic area. See, opposite to the aortic area, there is a pulmonary area. From here, the pulmonary trunk bifurcates. So here, you can get the sound of the pulmonary walls. Here you get the good sound of the aortic walls. And the third and fourth here our point is there. Here you can say, you can hear exactly in the middle of the body of the sternum, you can hear the labda. Okay, so that is a labda here, the space for these are points where it is a systolic and diastolic sounds you can hear nicely, S1 and S2 both. Then comes the below to that, on the lateral border, this left border of the sternum, that is a tricuspid area, because tricuspid is there upwards, but the sound is here because the blood comes from there, the sound comes here. So little bit this actually, if you check the tricuspid area is somewhere here on the right border, but where you are checking on the left border of the sternum, and so that is a fourth, that is in the fourth intercostal space. On level best to tell you the more information, but let us check what remains. You are supposed to check always and say the things. What is this? With a healthy heart, the beat goes on and on and on. And you are supposed to take care of your heart and keep heart beats on. Thank you very much. Thank you. I'm here taking opportunity to thank all my attendees who attended this lecture, and all SION Ayurved College and Ayurved Trustee of Ayurvedic Prasarak Mandal, Dr. Dudmal sir specially, who is actually organizing and organizing this webinar.
The concluding part, we conclude
and yeah, and my the chairman, Sir Pankaj Vishwakarma sir, will thank you for he is with me. Thank you. Thank you all of you. Thank you. I'm leaving. I'm leaving means I'm just please over to Dr. Vishwakarma sir.
Thank you, sir.
Thank you. Thank you.
Thank you, Londe, sir.
Yeah, thank you.
Thank you, sir, for sharing your valuable knowledge. For this session, we are blessed with Honorable Chairperson, Dr. Pankaj Vishwakarma, sir. Sir is recently working as Professor and H.O.D. Rachana Department at Great Kedari Redekar Ayurved College, Gadhinglas. B.A.M.S from Pursat Ayurvedic College. M.D. Rachana from Bharati Vidyapit Ayurvedic College, Pune. A B.O.S member, faculty member. Sir, now I request you to please guide your valuable input and conclude the session.
Thank you, madam. Thank you. First of all, good afternoon, everyone. It's my pleasure to be here with you in this webinar as a chairperson for this session. The eminent speaker, Dr. Ashok Londe, sir, has explained the topic is very well. The PowerPoint presentation, it is also good. Is good. He has also the clear the Ayurvedic perspective regarding the cardiovascular system, just such as Utpatti and then Akar, about the Akar. I know this. I know that this topic is very vast. This topic is very vast, but clinical application of cardiovascular system is a really a very interesting topic. And Dr. Ashok Londe, sir, has covered all the major aspects related to the system. All the major aspects. You know about it has covered all anomalies about the cardiac defect related to the development of the heart. It is also covered the just like about the anomalies of fossa valleys, ductus arteriosus. It completes all the topic related to the cardiovascular system. The cardiovascular system, I think that the cardiovascular system is one of the most important system. It is most important system in the human body. Knowing the system helps to understand its proper function of its clinical application in the practices. He has said to that the conducting system of SA and AV node explained very well. The cardiovascular system, it is the assessment will help to identify the significant factor that can influence the cardiovascular health, such as high blood pressure, high cholesterol level, smoking, diabetes, and the hypertension. Generally, the cardiovascular system, it is the assessment is carried out if symptoms such as a chest pain. It is carried out by the symptoms such as chest pain, unexplained sudden weight gain, then shortness of breathing, irregular pulse rate is seen, which is carried out by the ECG. It is carried out by the ECG reading. Then the Ashok Londe sir, special thanks to Dr. Ashok Londe sir, has given the informative and interesting lecture. The topic was easily understandable. The topic is very easily understandable for the student and even the faculty member. I thanks to organizing committee, Dr. S.M. Satpute sir, Principal SION College, Dr. Giri Gosavi Madam, H.O.D and Associate Professor in the SION College, Dr. Yogesh Gaikar sir, for conducting the nice lecture in this webinar. And also thanks to Dr. Ramteke sir, Vice Principal, and even congratulate Dr. Arun Dudmal sir, H.O.D and Associate Professor Rog Nidan Department, for successfully conducting this webinar series. It is very useful for the faculty members and it is very useful for the students. And once again, thanks to organizer for giving me the opportunity for being a chairperson for this webinar topic. Thank you, sir. Thank you, madam. Okay.
Thank you, sir, for your valuable guidance. Now I'm very thankful to our trustee member, Mr. Ranjit Puranik, sir, President of Ayurveda Prasarak Mandal, Dr. Ashan Town, sir, Secretary of Ayurveda Prasarak Mandal, Dr. Shyam Navar, sir, Treasurer Ayurveda Prasarak Mandal, for their guidance and motivation. I thanks our respected principal, Vaidya S.N. Satpute, sir, Vice Principal, Dr. Ramteke, sir, and Dr. Ravi More, sir, for their kind support and encouragement. I heartily thanks our eminent speakers, Dr. Sumedh G.Sonavane, sir, and Dr. Ashok Londe, sir, without whom this webinar would not be possible. I also like to thanks to our chairperson, Dr. Hina Sharma, ma'am, and Dr. Pankaj Vishwakarma, sir, who gave us their valuable time from their busy schedule. I thanks Dr. Dudmal, sir, webinar coordinator at H.O.D Rog Nidan department, for their technical support. I would like to thanks Dr. Yogesh Gaikar, sir, for conducting the second session of this webinar. Thank you all my colleagues for direct and indirect support. Thanks to all dignitaries and delegates for making this webinar successful. Thank you again. We will shortly inform you about our next webinar. Thank you once again.
Thank you, madam.
And
Thank
here
you.
I declare the end of the webinar.
Thank you, madam.
Thank you.
End